So I think that's all the time we have for Q&A, and we'll go ahead and move forward to our next speaker. So now we're going to move forward to increasing suicidal self-disclosure in therapy, testing transparent imminent risk descriptions. And I'll turn it over so you can introduce yourself and start.
All right, thank you so much. And really grateful for the other presenters because I feel like you did a bunch of the heavy lifting on some of these stats. Um, okay, assuming you can see my slide, my name is Jonah Hickman. I am a clinical psychology PhD student at the University of Louisville. This project has been a long time in the works. A precursor project, and this project will hopefully be published soon. We just gotta, get past a couple of reviewers, and then we'll be good. But just so I make sure I can get to all of it. When we look at suicide, there's a broad continuum of suicidal processes that I like to consider, especially when it comes to things like suicide disclosure. As we know, based on epidemiological data, for every one suicide death we have about 45 attempts, 94 individuals planning suicide, and 292 individuals seriously considering suicide in the same year. Also, for anyone who is at ADAA, I apologize, there's a few recycled graphics in here, so you'll have to bear with me. But as we look at this continuum, I like to consider where we are applying treatment and our various interventions or preventions. And what I mean by that is with things like hospitalization for suicide risk and risk assessments, are we doing downstream suicide intervention when things have gotten to such a level that that is all we can do? Or are we really prioritizing upstream suicide prevention in things like therapy or community outreach? As the other presenters have also mentioned, it's hard to get folks to talk to us specifically about suicide, or anyone, which is really hard because we can only really administer those treatments if we know that people need those treatments. Also of note, the hospitalization process is extremely overwhelming for a lot of individuals who do not disclose. I really liked in Chloe's presentation how much they focused on that because I think that it's a emerging and increasingly socialized fear among suicidal individuals. And, not without foundation. Some individuals are hospitalized and experience iatrogenic outcomes in their discharge, or they feel very poorly. They feel coerced or mistreated in those contexts. I think that this captures the element really well. This is from a paper, Love and Morgan 2021, where someone's describing their hesitancy to talk about suicidality with their therapist. It says, I was afraid to tell my therapist because I didn't want to be involuntarily sent to the hospital. I was afraid of having my choices taken away from me. But she did end up catching on to the fact that I was suffering too much and sent me to the hospital. But it was after we talked it out and I went voluntarily. And I think that there's a few key elements here. One, she was afraid of being hospitalized, but the therapist perceived that there was maybe a need and she then went voluntarily. I feel the need at this point to make sure everyone understands that I am not against hospitalization. It can be very helpful, including for some of the people who are nervous about it. In fact, some people will seek out hospitalization voluntarily, or they'll look back retrospectively and think, well, that was actually pretty beneficial to my treatment and having some of my recovery happen. But just because we keep hospitalization as a tool in our toolbox doesn't mean that we can't prioritize or optimize some of that upstream suicide prevention rather than relying solely on the laurels of downstream intervention via hospitalization and risk assessments. The other thing that I want to note here is that it seems like both our clients and clinicians are confused as to what we're supposed to be doing. Among clients, they're confused about when an involuntary hospitalization happens. Are they allowed to be suicidal in therapy? A lot of people on TikTok would seem no. But in other cases, they are able to talk a lot about it in therapy and they don't get hospitalized. On the clinician end of things, there's sort of a fluctuating sense of confusion or being overwhelmed about having to do the risk evaluations. How do you determine if someone's actually at risk or if it's just a symptom? When do you have to do mandatory reporting and when do you have to hospitalize? So I think that everyone would benefit from clearer and more defined definitions of imminent risk and some of these processes, which is really what we were trying to do with the current study. First thing, we wanted to describe hospitalization fears among individuals who had previously not been talking to therapists about their suicidality. Second, we wanted to identify how sort of those imminent risk descriptions that happen in therapy might impact disclosure likelihood, disclosing suicidal thoughts and behavior specifically. And then third, we wanted to sort of set the upper limit for how much hospitalization fear is limiting disclosure in therapy by sort of piloting a theoretical non-hospitalization policy. So what we did is this is still preliminary. We're still in the process of collecting data, but as of right now, we have 175 college and community participants from the Louisville metropolitan area. And the criteria for being in our study was just having a lifetime history of suicidal thoughts and behaviors. Our sample was pretty split in terms of people who had never been to therapy, people who had been to therapy but weren't suicidal at the same time, people who were suicidal and in therapy but weren't talking to their therapist about it, and then finally, about 21% were in therapy and they did share with their therapist sort of what was going on with their suicidal thoughts and behaviors. Um, Also of note, the different anxieties in these groups is interesting because the people who had never been to therapy actually had the lowest concern about being hospitalized by a therapist. But among people who had been to therapy but not while they were suicidal, people who were seeing someone while they were suicidal but not talking about it, and the people who were being honest, a majority of them are worried to a substantial um, rating, at least, that they would be hospitalized for expressing the feelings that they're having with suicidal thoughts. So that leads us to our second aim. How might our descriptions of imminent risk in therapy help or hurt the client's likelihood of telling us about their suicidal symptoms? To do this, we randomly assigned individuals to a condition, either a control or one of three conditions where they receive a prompt. And in this prompt, the participant reads it, it describes imminent risk to some extent, and then they answer questions about how likely they would be to disclose given that information if a therapist presented them that content. Also of note, each condition is additive, meaning that the content of A is also in B, but B adds a little bit more, and then C adds a little bit on B. And so this is the question that we were asking them up top. We have them imagine that they're suicidal, whether they currently are or just were in the past, and then also imagine that they're in a session with a therapist. The controls got no prompt. We just had them sort of indicate how likely they would be to disclose to their therapist. Then we had sort of a standard information prompt for this first group, where this is the content of pretty much every consent document, at least that I could find, where it talks about confidentiality, things are private, but there's the mandatory reporting element where potentially the therapist has to break confidentiality and reach out to emergency services. From there, the next prompt has the exact same content, except it also has a definition of what imminent risk means. I think sometimes as clinicians, we forget that our clients don't know our jargon, and so it defines imminent risk. It means that the therapist has reason to believe you are highly suicidal, have access to a method to attempt suicide, you have a plan, and are likely to act on that plan before your next session. So there's some very clear guidelines set in this definition. And then with our final prompt, it has all of the previous elements, but it also gives an example in which someone expresses to their therapist that they're suicidal. They vaguely have a plan and a method, but they don't think they're going to go through with it for like another couple of months. And it indicates that this is an imminent risk. They can keep working outpatient in therapy with this level of suicidal thinking and planning. But if the timeline shrunk to the next week, then that's going to be a problem. Of note, when we analyzed this, the standard prompt did worse than the control condition. It is in some ways worse to tell people sort of our standard blurb than to say nothing at all. Also of note, the extra information and the example condition was the one that got the highest. The average there was almost a 4 on a scale from 1 strongly decreases the likelihood to 7 strongly increases the likelihood. However, even though this is better apparently than our standard prompt, none of these are doing better than sort of a neutral, neither increases or decreases. And I'm being mindful of time, but this is where the final analysis comes in. We piloted sort of this no hospitalization policy. We give people a guarantee that they won't be hospitalized, even if they are acutely suicidal. And what we found is in every single condition, this increased the likelihood that they would disclose. Not all the way, it's not at the top of the scale, but now every single condition is more likely to disclose than not, which I think is substantial. The limitations of this, it's not a clinical and it's a primarily undergraduate sample. It's still underpowered because we're not done collecting data. And, I think that some of the elements of the incomplete extension all the way up to the top of the scale might be because there's other elements that are preventing people, like stigma. And so I think that the takeaway from this is that we just need to be very clear with our clients and ourselves about what imminent risk is. And on a more policy level, I think that we need to be deliberate about whether we prioritize that last minute intervention for some people or an upstream utilitarian trade-off of helping more people upstream by giving people some like non-mandatory involuntary hospitalization qualities as a clinician. So I'm happy to answer any questions about that. I know I'm over time, but I appreciate your time. Listen to me, yeah.
Well, thank you very much. It was very informative. And I'll go ahead and ask you some questions. The question here is, so this is an interesting study design. What do you think the next steps are? How could we use this information while balancing all of the ethical and pragmatic contexts out there, such as, we can't make hospitalization illegal, right? And I related to this. This is basically what I was going to ask you to.
Yeah, yeah, no, and I think that that's a very real question. I think the solution is giving people options. Just as some treatments work better for some people and not others, I think that since we have a substantial amount of the population who is not disclosing, because potentially these hospitalization fears, perhaps there is a special classification of suicidologists in which they are qualified to work with someone outpatient, understanding that there's risk there. And I just think that if we could designate that, we would get more people better than by sort of keeping this silver bullet of hospitalization as our only way to intervene. So, yeah, did that answer your question?
Yeah, no, I think so, right? It's unfortunately it means like accepting some level of liability or at least exposure, really,
Yes, yeah.
to the situation. Another question would be, how did you develop these prompts? And they're curious if it included clinician perspectives in any. Are you thinking of including clinician perspectives in the next steps?
Yes. So one of the next steps is doing qualitative interviews with folks who are participating in this study right now. We're going to pull some into the lab and see what elements are the most important, what are sort of negligible, but then also like a clinician feasibility step where we just try to figure out if people would even be comfortable having someone in their office who they're not going to they don't have the option to hospitalize or there's more transparency such that the clinician doesn't have all the power and it's a little bit more distributed between the client and the clinician.
No, really good. Thank you so much. And thank you for the questions, everyone. So we'll go ahead and move to our next speaker.